Good morning, friends. I am delighted to present to you the effectiveness of a new product called HALT technology for the retardation of progressive myopia in Indian children. I have no conflict of interest in any products mentioned in this presentation. As all of us know, the prevalence of myopia has been increasing all over the world, including our country. It is almost 5 times increased over the last 10 years and expected to cross 50% prevalence by 2050. What is more concerning is the increase in the prevalence of pathological myopia, which is increasing by 3 times faster rate than the low myopia, more so in urban areas. And thereby it increases the risk of late ocular complications such as retinal detachment. So the aim of management of progressive myopia in children is to slow down the progression to make sure that these children are saved from the negative impact of pathological myopia in future. To achieve the goal, myopia control in India started with introduction of low dose atropine back in 2017, followed by introduction of MyoSmart lenses by Hoya in 2021, followed by HALT, which was introduced through Stellest lenses in 2023. As of now, we have few studies available on use of low dose atropine from India showing maximum reduction of progression by around 57%. Dr. Shruti Nishant's study from South India shows significant reduction in progression to up to 75% using MyoSmart of Hoya, but such data is not available from Stellest, which is a more advanced technology of spectacle lens. It has higher volume of myopic defocus. So the aim of the study was to find the effectiveness of this new product in slowing down the progression of myopia. It's a retrospective single center observational study in which 16 consecutive myopic children having a progressive myopia at the time of recruitment between 1 to 8 diopter were included, who had no other ocular comorbidity and astigmatism was less than 4 diopter, with a baseline progression of at least 0.5 diopter per year in the previous year. All of them were prescribed Stellest lenses for full-time wear. Minimum 12 hours per day of wear was required to be included in the study. Before and after the use of Stellest, spherical equivalent refraction was measured and significance value was assessed using a paired t-test. We had 5 patients among 16 who also wanted to continue or rather start with 0.01% while they were using Stellest lenses once at bedtime. This constituted another second group in which there was a combination therapy, and we used group t-test for assessment of p-values. Of 16 children, 6 were females with an average age of 10.5 years plus minus 3 years. Mean myopia was minus 4 diopter ranging from 1 to 8, and mean follow-up was 10 months ranging from 6 to 18 months. The efficacy of Stellest lenses was found to be 87% with a reduction of pre-treatment 0.8 diopter per year to 0.1 diopter progression per year. When we compare two groups, the second group in which Stellest was used along with 0.01% atropine, we found it to have significantly higher effectiveness, however significant in the clinical sense, but statistically it was 0.59 because of small sample size. None of the patients who used combined therapy had any progression. So in all, it seems this new defocus lens has superiority in terms of reduced progression of myopia. The numbers seem to be too good to believe, and of course, why not? There could be limitation in this study, like being retrospective in nature, lack of control group and randomization, small sample and small follow-up, lack of measurement of axial length, and also we did not look at the side effects of use of these lenses or other confounders. However, there are 3 studies available across the world. All of them have shown that defocus lenses are superior to low dose atropine by at least 10%. So in conclusion, they seem to be better than the existing atropine use When combined, it becomes even better, and further studies are required with larger sample size. Thank you very much.
Thank you, Dr. Mihir. I think if these lenses are able to halt the progression, they will just justify their name as well. Like we have seen that with atropine eye drops, the patients have not been that compliant. So if these lenses can be that good that as have been claimed, definitely that they could be of great use. Only thing is that the sample size, as you already commented in the limitations, so only like 10 people were from not the mixed group. So that needs to be, I think, be well justified to come up with validated results, I guess. And what are the like side effects that, if you could mention regarding these lenses?
Sir, the potential side effects, there is one study available from Sumita Agarkar from Shankar Netralaya, where they looked at the child complaining of peripheral blur, eye strain, headache, and like in multifocal lenses or EDOF lenses used in intraocular lens segment, they also can complain of halos and the starburst appearances. In our study, none of the patient had this complaint. Not even adaptation time was required in our 16 patients. In her study, she has shown that around 10% patients can have this complaint, but it doesn't make it intolerable. And after around 2 weeks of neuroadaptation, most of them are able to use it, sir.
Actually, Dr. Mihir, I had one query.
Yes, sir.
You see, the proof of the pudding would be if we did a crossover on it. Did the thought of a crossover come in your mind? A crossover or a double crossover kind of a thing?
So right now there are three studies available. One is a randomized control trial in which the patients were, these are expensive lenses, so making them crossover, it's a 18 to 20,000 rupee spectacle lens. Plus it's been there since 2023 only. So getting at least 1 year, ideally 2 years is required, because first year effectiveness is supposed to be higher than the second year's effectiveness for these lenses. So for crossover, after 2 years we will be able to cross them over, but it's a good suggestion for an individual child. However, again, the age of the child has increased by the time we actually cross over
Yeah, so
to new.
that's going to be
So that's a confounder for us, sir.
that's
So
going to be a confounder.
I think RCT, parallel RCT would be a better idea, sir.
Yeah. Anybody has any questions? So I think we could go to the next speaker.